Inferior myocardial infarction is among the most frequently encountered heart attack in pre-hospital care. It accounts for approximately 40 to 50% of all STEMIs that we see. So in this video, we will take a closer look at the underlying processes occurring within the heart during an inferior myocardial infarction. We will explore various aspects, including atherosclerotic plaque formation, artery blockage, oxygen-deprived cardiomyocytes, involvement of the conduction system, and that release of troponin that we see in our blood work. So gaining an insight into this pathophysiology will enhance our comprehension of our patients' presentations. It also provides foundational knowledge regarding the rationale behind administering specific medications or treatments. So in the UK, we still experience approximately 100,000 hospital admissions annually due to acute myocardial infarction. So that equates roughly to 1 every 5 minutes. Additionally, around 40 to 50% of these MIs, these heart attacks, affect the inferior wall, which is the lower surface to the left ventricle that rests on the diaphragm. However, these heart attacks do not occur just suddenly. Their origins will trace back from years earlier, beginning with a gradual silent process known as atherosclerosis. So over time, cholesterol, fats, inflammatory cells accumulate within the lining of the coronary arteries. This will create a fatty streak that slowly develops into a raised plaque, an atheroma. This plaque narrows the artery and reduces its flexibility. Usually it remains dormant, but the real threat will arise when that fibrous cap covering it becomes unstable. When that cap ruptures, it reveals the soft lipid core to the bloodstream. The body reacts as if it's a wound. Platelets will rush in, adhere to the site, and initiate that clotting cascade. Within seconds, a thrombus begins to form on top of that ruptured plaque. If this clot becomes sufficiently large, it can completely block and occlude that coronary artery. So, in the majority of individuals, about 80 to 85% of people, this event occurs in the right coronary artery. Blood flow to the inferior wall of that left ventricle, and often a portion of the right ventricle, is halted instantly. Within seconds, the cardiomyocytes located downstream of the blockage cease to receive oxygen-rich blood. Typically, these cells depend on that continuous oxygen supply to generate ATP through aerobic metabolism. When oxygen levels drop, they switch to anaerobic glycolysis, which produces significantly less ATP and generates lactic acid. This results in a decline in intracellular pH, chaotic calcium handling, and a loss of energy essential for contraction and electrical stability. Just 1 minute after the total occlusion, you can observe decreased ATP levels and contractility in that area. By around 10 minutes, the cells become electrically unstable, and by 20 minutes, structural damage starts to occur. If perfusion is not restored, cardiomyocytes begin to die irreversibly at quite an alarming rate. Research indicates that after approximately 20 minutes of total ischemia, you could lose around 500,000 to 1 million heart muscle cells every second. Now that's going to equate to about 1 gram of myocardium per minute. So in just half an hour, you could permanently lose tens of millions of cells. Once these cells die, they cannot regenerate. Cardiac muscle does not replace itself in the same manner as the skin or the liver tissue. As the membranes of these dying myocytes disintegrate, their internal structural proteins leak into the bloodstream. The most clinically significant of these are the troponins, specifically troponin I and T, which are typically only found in cardiac muscle. Troponin levels begin to rise around 3 to 4 hours after the onset of infarction. They will peak at approximately 24 hours and can remain elevated for up to 10 days. So when we see our raised troponin, especially the cardiac specific ones, we know that the heart is under stress and there is heart damage happening at that point in time. The right coronary artery not only supplies the inferior wall of the heart, but also the AV node, and in about 30 to 40% of cases, part of the right ventricle. Therefore, a single occlusion triggers a sequence of events. Ischemia affecting the AV node slows down conduction throughout the heart, leading to the bradycardias and the AV blocks we frequently will observe. Furthermore, if the right ventricle is involved, its ability to pump blood into the lungs diminishes, causing a loss of preload in the left ventricle and a sharp decline in blood pressure. So in our patient assessment on the monitor, you may observe a slow junctional rhythm and hypotension. This is all a direct result of what's happening on a microscopic level. All of those cells dying, the oxygen deprived cells failing simultaneously. This is why the phrase time is muscle isn't just a cliche, it's the literal truth. It's not just something that's said in training school, because with every passing minute that a coronary artery remains blocked, more myocardium dies, troponins going to rise, and contractile function is inevitably lost. So let's have a look at a minute by minute look at the damage that's occurring after the occlusion. So if we have, say, 0 to 1 minute, what we're going to see is a decrease in ATP and impaired contractility. If we have 10 to 15 minutes, we're looking at electrical instability will start to begin. 20 minutes to 30 minutes, we have irreversible cell death. And like we said, that is 500k to 1 million cells per second. At the 1 to 2 hour point, necrosis spreads from that subendocardium outward into the layers of the myocardium. 4 to 6 hours, we have troponium is detectable in the blood. And then 24-hour period plus, we've got peak biomarker release, inflammation starts to begin. So to summarise the pathophysiology of an inferior myocardial infarction, MI, the rupture occurs in the plaque within the right coronary artery, halting blood flow to that inferior wall. Cardiomyocytes switch to anaerobic metabolism, leading to decreased ATP levels and increased acidosis. Irreversible cell death begins within 20 minutes, with around 500,000 cells dying each second. Damaged cells will release troponin I and T into the bloodstream, serving as our biomarker for myocardial injury. Ischemia impacting the AV node and right ventricle causes bradycardia, hypotension, and increased preload sensitivity. This series of events is what we face when encountering a patient with an inferior MI. Millions of starving cells and a compromised conduction tissue pathway. So thanks for watching. Please make sure you are subscribed to the channel so you get notified of all of our new videos we're going to be releasing over the coming weeks. And also hit the link in the description. It will take you to our website where we've got all sorts of emergency medicine, pre-hospital, education and products.